case study about sepsis.
All right.
So I'm just going to read like a brief um, chief complaint of a patient and some information when they came in, and then we'll just kind of talk through like sepsis care.
I love it. All right, let's do it.
So we have a 73-year-old female that arrives via EMS from a skilled nursing facility. Patient complains of urinary frequency and burning.
Okay.
Vital signs at the time of arrival: a temp of 35.9 Celsius,
Okay.
respirations of 20, heart rate of 101, BP 98/54, and a pulse ox of 99% on room air.
Okay.
All right. What do we think? We covered triage last time.
Okay.
So what do we think we want to ESI this patient? And
I'm going with a 2 based on what you told me.
Yep.
Below temp. They're not fully tachycardic yet.
BP was 98/54.
So hypotensive-ish. For me, the other red flag is she's 73 and in a skilled facility, which means there's comorbidities or history that I don't know about that's going to help her be high risk.
Yeah, for sure.
You don't live in a skilled facility at that age for
no reason.
Yeah.
So I agree. I would definitely put it as ESI too. And then what do you think we, at least for me, with the vital signs, would you say it's sepsis now or more of like the SIRS criteria?
I would go with SIRS criteria to start. It's definitely heading towards sepsis, with most likely being urosepsis with her chief complaint.
I agree. I thought the same. And then for nursing care for sepsis, what are, like, just talking through the ER nurse's life for a patient that we're considering is maybe septic?
Sepsis bundle.
Sepsis bundle.
Is the 3-hour and the 6-hour, and the ER lives in the 3-hour world.
So initially, I think as that primary nurse, right, you're going to complete your assessment, all of your required documentation, IV, because you know you're going to need IV placement on this patient, urine sample for sure.
Yeah, and I know it's kind of taboo, but I'm going to say it. I would go straight for the straight cath.
Yeah, you need a clean sample.
Yeah, I'm not going to mess around. You're in a skilled facility, which means you need some sort of care. You're complaining of frequency and burning. I'm going straight for the straight cath.
Yeah. And you can totally advocate that with the doc.
Yeah, I know some hospitals, because some ERs are designated as like a no Foley zone. And so I think people forget that the straight cath is a tool, not necessarily a. It's not the old school. It's a straight cath, meaning I'll take it out when they get the bed assigned.
Right.
It's truly.
I mean, and I think too with the patient's complaints of urinary frequency and having the vital signs that she does, it's important to get a clean sample.
I won't think of this initially, and what will happen is I would get the straight cath. I thought about this after I said straight cath. I would be like, damn, I should have done a bladder scanner. Because if you bladder scan before, you can see if there's any retention, do pre and post.
Yeah,
I wouldn't have thought about it until after, though.
Yeah,
but then I would be like, oh, she had frequency. And I know, at least in what I'm seeing recently, like out with the patients, is docs are going, let's bladder scan first. But it just wasn't a tool I used all the time when I was at the bedside. So
no, me either.
Yeah.
But it is definitely a tool that is available now to use. And that's a great point.
Yeah.
So we're talking about labs. What labs do we think?
All right, sepsis bundle. Well, your kicker, right, for your sepsis bundle, your sweet spot, your lactate. But I'm going to go in order of what I would, not in order how I would draw them, but what I would draw. We said hypothermic, hypotensive, tachycardic.
Yep.
With urinary symptoms. I'm getting a set of cultures.
Yep.
Off the bat.
Set of blood cultures.
Set of cultures. I'm going to do sets of cultures. I'm going to do CBC, chemistry. Depending on I'm definitely going to get the lactate. Coags if she's a coag person, but not like a top of mind, not a priority. And then depending on her history, maybe a finger stick.
Okay.
Just because when you're starting to talk UTI, you're thinking like hyperglycemia and all that other stuff. And some facilities do procalcitonins.
Okay. So for our CBC, we could potentially see increased white blood cells. And then the lactate. For us, the magic number is kind of 4.
Yeah, 2 we start going, oh, there's something brewing. 4 we go, oh crap.
It's
Higher
brewed.
level of
It's
care.
brewed.
Higher level of care.
Yep.
Yeah.
So definitely blood cultures before antibiotics
Oh yes. Both
because
sets.
yes,
Both sets.
because obtaining the blood cultures after the antibiotics doesn't make too much sense.
No. And I know that there are companies out there, there are blood culture bottle companies that do have an additive that allegedly like can either defer that or soak it up or something. I forgot
The
the actual.
antibiotic?
Yeah. So
Stop.
yes, I can never say the name of the company.
I'll have to look it up.
It's Bio whatever. The ones
Hmm.
the Biomu, they have that. So there's like if you look in the bottle, some of them have like this little like they have like these gray-ish beads in them.
Interesting.
Yeah. So
I'll
it's
have to look
supposed
it
to
up.
help.
I'll have to look it up. I'm not sure what
Yeah.
it's called. So the blood cultures before the antibiotics, and then antibiotics within 1 hour of diagnosis that we're thinking that this patient is septic.
Yes.
So that is definitely a thing that a goal that we have on a timer.
Yeah, and it's a national goal. It's not like it's different per hospital. Like
Institution, right?
sepsis bundle is regulated by the CMS. It's regulated by the feds.
So the antibiotics within 1 hour of diagnosis, blood cultures before antibiotics, and then for me at least, I always see broad spectrum antibiotics.
Yeah.
You know, it's
Hands
usually
down.
vancomycin and Zosyn, vancomycin. And then, at least from my time on the floor, and I'm sure it's still this way now, we really want to try to give the Zosyn first, just because it's given over that 30 minutes.
Yeah.
It can cover it, and then you can give your vanco. It takes a little bit longer. Usually like an hour to run vanco.
And Vanc has, I mean, obviously with your risk of Zosyn, you have to check your allergies. You're gonna have potential, but Vanco has, I want to say it's more of a risk, and Zosyn infiltrates bad, any kind of IV infiltrate. But if Vanc infiltrates, it's.
And I know we've had mixed reviews from the pharmacy team that we work with about running those meds together. It's not a great idea. It's not really best nursing practice to say,
Yeah.
This patient's going to get vancomycin. I'm going to run both of them at the same time, one on opposite arms. Because if that patient then has a reaction, we don't know what they're reacting to, and you're potentially eliminating a group of antibiotics this patient can receive, or potentially 2 groups of antibiotics this patient can receive, and that can be detrimental in the long run to the patient. So running your Zosyn for the 15, 20 minutes, and then if you're really desperate to start that vanco, and the team is pushing you or you really need to get it started, I think at that point it would be okay, but I don't endorse that, heavy hitter running fair. Them at the same time.
That's fair.
I mean, I think unless the patient is truly just crashing and we've passed that kind of like septic.
Yeah. It's interesting with Vanc and Zosyn, like, so with boarding being the way it is all over the place now, everyone being sick and not having hospital beds, ERs are seeing like the next phase, right, of antibiotics, the second round, I'll say, of antibiotics. The Zosyn's given over 4 hours.
Yes, it is.
In that case, I would give my Vanc first. Because Vanc's always just an hour.
Yeah. No, I agree with that.
Right? And you don't really need to worry about the level, and they worry about leveling and dosing and kidney stuff after the second level. So right before the third dose is when they're going to worry about the trough and all that. But I'd give the Vanc. So
on the second time around, the Vanc first, because it's just an hour.
Just an hour, and because Zosyn standardly is given over 4.
Right. Yeah, no, that's reasonable.
Yeah, and it has to do with like the way it peaks. So it's actually staying higher longer by giving it
over a longer period of time. That makes sense.
Yeah.
So antibiotics within that 1 hour of suspected diagnosis of sepsis, and then fluid resuscitation is 30 milliliters per kilogram.
On your standard healthy patient.
Yep, on your standard healthy patient. Never mind like the CHF and all that.
And you can count your pre-hospital fluid.
It's just documenting it.
Oh.
Documenting that and communicating it with the team, but in general, 30 mils per kg, so long as the patient can tolerate it. And that is if the lactic is greater than 4, or the patient has hypotension to go along with it.
Okay.
But most of the time, when you're meeting that SIRS criteria and the patient is working towards sepsis, you're already there.
Yeah,
it's already happening. So if you have the patient that is, we've identified her as SARS initially when she came in, hypothermia is actually a common complication of being septic. And most of the time people think, oh, they have an infection, they're going to develop a fever. And I feel like we tend to see the hypothermia more in elderly patients
Yes.
than we do in our younger population. So hypothermia is a real effect of sepsis, which we see. And sometimes newer nurses don't pick up on that. They don't pick up on the hypothermia as a SIRS criteria.
You'd have to actually take a temperature.
Right.
And then it's, remember, I know that some facilities, and luckily when I was at bedside, I never did it because I can't stand it. I never mastered them. Tympanic, useless.
Yes. I
And
honestly,
even the temporal, I find it useless.
I'm here with that. I agree.
And I know when COVID was big, we got into those like paper, the brand was Tempadot, but like,
oh yeah. To me,
you'd have to,
you cannot, the benefit of a rectal temp.
Yeah, I 100%
I mean,
agree.
It's good nursing. It's good for the patient.
Yeah.
You're going to serve the patient best. Get the rectal temp and know what the patient's temp is. And many times the patients that are like borderline, right? Like I'll see nurses with the probe in the mouth forever and ever and ever. And it's like, okay, try a rectal temp because it's not registering on that oral temp for a reason.
Yeah.
Like just roll the patient and do it.
Temp of 35.8 reminds me of the blood pressure being 98 over whatever you said. Instead of trusting it, what do? Oh, we go get another method of taking it, or don't put a smaller blood pressure cuff on.
Right. Don't try to make it better when it's not.
Yeah, no.
Just treat the patient.
Yeah, please.
So yeah, the fluids which we just talked about, but the hypothermia too. It's not. I feel like it's just not as widely recognized as someone being febrile. And then you will have the follow-up of the sepsis care bundle 6 hours from the initial diagnosis, which is your repeat lactic acid, and then kind of reevaluation of the patient to see if they've now made themselves completely septic and in septic shock. One thing that I didn't write down on here, but I think it's worth just mentioning, is that if you do have that patient that goes into septic shock and they become hypotensive, the standard of care for meds.
Pressors.
And Levophed tends to be
Levo is the number one pressor for sepsis right now, nationally. Yep. And it's funny. It's not that it's funny, but I've been a nurse for so long that everyone was scared of Levophed, right? Like Levophed, leave them dead. That's what that was like the saying. A lot of places, and I've seen smaller hospitals, not so much bigger hospitals, tend to not that they stay away from Levophed. They're hesitant to give it till they get that central line. It can be given peripherally to start.
Yep.
Optimally, you need the central line.
Definitely over long term, and absolutely if it's high concentration.
Yeah, because the higher doses you get, the more you worry about vasoconstriction. And I have seen people have necrotic fingers and toes from being on.
They've lost limbs.
Yeah.
From being on extended Levophed or extended pressors.
Yeah.
But Levophed is absolutely the go-to for sepsis. And I find too, when we're giving Levophed to those truly septic patients, they're very responsive to it. Very responsive.
They just need a little help.
Yeah, just a smidge.
Just a smidge.
It is interesting though when you do have that septic patient that you kind of see present with SIRS, and then you're like, oh, I know this is going south, right? And they become completely septic. And then you really get ahead of the antibiotics, the fluid resuscitation, getting them on Levophed. Patients truly do turn around.
Yes.
If you can get that bundle in and really like recognize those signs and symptoms and advocate for the patient, they really do turn around quickly. So I think knowing that treatment plan and whatever your institution's treatment plan is, I mean, like you had mentioned, there's national goals for this, but I'm sure each institution has a slight difference in what they're doing.
Well, I will say from where I've worked, the biggest difference I've seen in the different hospitals I've worked in is what is considered ICU level of care. So some, like your lactate is 4, you need ICU level of care. Other places like your lactate is 4, but you're awake, alert, mentating fine.
Sure.
We can handle you on the floor. Hospital med admission.
Yeah, I know for us it is more than 4, you don't go to the floor.
Right. That's what I'm saying. It's like, oh.
Yeah.
And that's kind of like was my mindset until I went to one of the last places I worked. And I was like, why is this going to the floor? Like, well, we've corrected the blood pressure. They're not on pressors.
They've had their fluid
resuscitation. They've had their first dose of antibiotic.
Yep.
Now they're just on maintenance fluids. and their mentation status is so good, there's no reason to not.
Right. You're just probably trending that
Yeah.
lactic
Because what
down
is
at that
what
point.
is the ICU going to do that the floor is not? You're going to wait till your hour 6 to redraw
Redraw.
that
Right.
lactate. You're not going to redraw the white count. You know it's high.
Right.
Yeah. Interesting.
All right. Anything else to mention about sepsis?
No, I just definitely vital signs matter, including a temp is really big. Blood cultures before antibiotics. Don't be afraid to tell the provider you think it's going that way. Like, hey, what do you think? Or you think should we?
Just advocate for the patient.
Yeah, pretty much.
Nursing is eyes and ears at the bedside. We know what is happening with the patients. And there's a lot of, I think, secure chat and messaging. It's okay to approach the team and say, I think this patient is circling the drain. We need to kind of intervene now before it's too late.
Yep.
Creating those relationships.
Trust your assessment.
Yeah, definitely.
If there's one skill you, not say you master, but you at least you learn and practice through all the different years of nursing, whether you are an associate's degree, a diploma degree, is your assessment. And it's the one skill you use every day.
Absolutely. All day.
You might not put an IV in for 3 straight days, but you're going to be using your assessment skills. So trust them.
Yeah, it's a great point.
Yeah.